Now we are going to discuss the renal tumors. In renal tumors, first we will discuss the benign renal tumors. So let's start with angiomyolipoma first. Angiomyolipoma. Okay. So in surgery, it's very easy to remember the terms. If you do the surgery of terms, what is the meaning? See, the term is angiomyolipoma. So let's break it. It is angio plus myo plus lipoma. So it is the benign tumor which is composed of angio means matured vessel, myo means muscle, lipoma means fat. Okay. So what is this angiomyolipoma? This is benign tumor and it is composed of angio means matured vessel, myo means muscle and lipoma means fat. Clear? Generally this angiomyolipoma, it is more common in females and it is usually seen in 5th to 6th decade. More common in females and it is seen in 5th to 6th decade. There is one question which is frequently asked in medicine as well as in skin. The question, association of angiomyolipoma. So it is associated with tuberous sclerosis. And in tuberous sclerosis, if angiomyolipoma is there, see generally angiomyolipoma is single and it is seen in 5th to 6th decade. But if angiomyolipoma is associated with tuberous sclerosis, and in tuberous sclerosis, if angiomyolipoma is there, it is seen in young patients, it is multiple and bilateral. Clear? There are 2-3 questions which are asked in pathology also, that on immunohistochemistry there is one marker which is positive in angiomyolipoma as well as malignant melanoma. So what's that marker? The marker is HMB45. So HMB45, this is a marker which is positive in angiomyolipoma and in malignant melanoma. This was asked many times. Second pathological feature, that in angiomyolipoma there is presence of macroaneurysm. And what is the problem associated or related to macroaneurysm? So these patients have macroaneurysms. Okay. And because of this macroaneurysm, what will be the problem? See the location of kidney. Kidney is located in the retroperitoneum. So whenever this macroaneurysm is going to rupture, what kind of hemorrhage will occur? Obviously, retroperitoneal hemorrhage. And this retroperitoneal hemorrhage is seen in 10% of patients. And the name of this condition is Wunderlich syndrome. Clear? So macroaneurysm, it leads to retroperitoneal hemorrhage, and this retroperitoneal hemorrhage is seen in 10% patients. And what's the name? This name is asked in exams. It's the Wunderlich syndrome. This is Wunderlich syndrome. Clear? Now see, in majority of cases angiomyolipoma is asymptomatic. It's a benign tumor and it is asymptomatic. So how we are going to diagnose any asymptomatic tumor? This is diagnosed incidentally on radiological investigations. Clear? So whenever we are going for CT for something else in abdomen and we are going to find that yes, there is angiomyolipoma in the kidney, right? So clinical features, majority of patients are asymptomatic. Clear? And this is diagnosed incidentally. So the condition is diagnosed incidentally. Okay. We discussed that for most of the retroperitoneal pathologies, what is the investigation of choice for diagnosis? It is CCT. Second important point, for most of the renal tumors, investigation of choice for diagnosis is CCT. So what are the exceptions in renal tumors where CCT is not the investigation of choice? First, Wilms tumor. For Wilms tumor, the investigation of choice for diagnosis is MRI, and whenever there is lymphoma anywhere in the body, investigation of choice is biopsy. So if there is lymphoma in the kidney, what is the investigation of choice? Biopsy. Okay. So see the diagnosis. So how we are going to make the diagnosis? Investigation of choice for diagnosis, and this is CCT. For most of the renal tumors, exception Wilms tumor, where MRI is investigation of choice, renal lymphoma, where biopsy is investigation of choice. Now see, in any patient, when we suspect the renal tumor or there is renal tumor, okay, in that case our first priority is to rule out whether this is RCC or not. And if RCC is ruled out, then we have to focus that if it's not RCC, then what's the tumor, right? Now see, one of the characteristic feature of RCC is what? Presence of calcification. And in angiomyolipoma, the name is angiomyolipoma. So what is one of the characteristic feature of angiomyolipoma? Lipoma, presence of fat. So how you will differentiate angiomyolipoma from RCC? There is absence of calcification and presence of fat. Okay, so on CT there is absence of calcification, clear, and there is presence of fat, okay. On CT, fat is having -20 Hounsfield units. So if you do CT, generally fat will be having relatively black appearance. There was an image based question asked in AIIMS. See the image. Now see this image. Here you can see what? That there is presence of a tumor in both kidneys. So there is bilateral tumor and it's multiple. Okay, appearance relatively black, and it is having regular and smooth margins. Can you see the margins? It is having regular and smooth margins. So it is looking like a benign tumor. And what is this tumor? This is angiomyolipoma. So this was the image based question. Clear? So here you can see angiomyolipoma. Since it is bilateral, it is multiple, so the chances are that it is associated with which condition? It is, this patient is having what? So this is association, right? Diagnosis is done. Now coming to the management, we discussed that in majority of cases patients are asymptomatic. So see, if the patient is asymptomatic and size of tumor is up to 4 centimeter, only observation is done. And if patient is having symptoms or size is more than 4 centimeter, in that case we have to remove the tumor with margin, and this is known as partial nephrectomy. And what is the other term used for partial nephrectomy? It's known as nephron sparing surgery. Okay, so see, management, it's easy. If the patient is asymptomatic and the tumor is up to 4 centimeter, in these cases we go for observation. Clear? When the patient is symptomatic or the size of tumor is more than 4 centimeter, in that case we go for nephron sparing surgery. And what is the other term used for nephron sparing surgery? This is also known as partial nephrectomy. Simple. Now imagine sometimes patient is coming to your emergency because of bleeding. So if bleeding starts in the tumor, then we go for angioembolization. So if the patient is having bleeding, so for this bleeding manifestations, what is done? We go for angioembolization. Clear? So this is how we manage the angiomyolipoma. Next tumor is renal oncocytoma. Okay, renal oncocytoma. This renal oncocytoma, it is responsible for 3 to 7% of solid renal tumors. So how much percentage? It is responsible for 3 to 7% of solid renal tumors. Okay, I told you that in surgery, do the surgery of terms. So this is oncocytoma. So it arises from what? Oncocytes. Oncocytoma means it arises from oncocytes, and these oncocytes are rich in mitochondria. Clear? So it's easy to understand. Oncocytoma, it arises from oncocytes, and these oncocytes are rich in mitochondria. Okay, because of this kind of appearance, it appears or it mimics one variant of RCC, and which variant is the chromophobe variant. So it's the exactly eosinophilic variant of chromophobe RCC. So this renal oncocytoma, it mimics, this is important, it mimics eosinophilic variant, eosinophilic variant of chromophobe RCC, right? Now see, most of the questions which are asked related to renal oncocytoma, it's from pathology and radiology. Okay. So we discussed it is rich in mitochondria and it mimics eosinophilic variant of chromophobe RCC. One. Second, what is the investigation of choice for diagnosis? And the investigation of choice for diagnosis is CCT. So what is the typical appearance which is seen on CCT? So here you can see that this patient is having renal oncocytoma and this kind of typical appearance is there. So within the tumor, what kind of scar? There is central stellate scar which is seen. Okay. So diagnosis, important points, investigation of choice for diagnosis, and that's CCT. And on CCT, you see this appearance, and this is what? Central stellate scar. Right? Central stellate scar. This is one question. Okay. And whenever we perform angiography, what kind of appearance is seen? There is cartwheel or spoke wheel appearance. So on angiography, there is spoke wheel appearance. Clear? How we are going to treat? Since it's a benign tumor, obviously we go for what? Nephron sparing surgery or partial nephrectomy. So what's the treatment? It's the nephron sparing surgery or partial nephrectomy. Clear? Now one famous question of radiology: what are the tumors in which central stellate scar is seen generally in surgery? So the tumors in which central stellate scar is seen, one we discussed, it is focal nodular hyperplasia. Second, fibrolamellar variant of HCC. Third, renal oncocytoma. And fourth, serous cyst adenoma of pancreas. Be careful, it's what? Pancreas. In serous cyst adenoma of ovary, samoma bodies are seen, but central stellate scar is seen in serous cyst adenoma of pancreas. So these are the four important tumors in which central stellate scar is seen. Now we are going to discuss RCC, renal cell carcinoma. First we will be discussing the pathological aspect of RCC and then we will be discussing the surgical aspect. So first let's discuss the pathological aspect of RCC. Okay. Question: what is the most common variant of RCC? And it's the clear cell variant. So first, what's the most common variant? It's the clear cell variant. Okay. Now see, it's the most common type of RCC. The name suggests that it is clear. So cell is clear. So actually speaking, this cell contains glycogen and fat. Whenever we are doing the staining, yes, this glycogen and fat is washed away by acetone and alcohol. So cell appears clear. So cell appears clear, but cell is not clear because cell contains glycogen and fat. So see, the important points related to this tumor is the most common variant of RCC. It arises from proximal convoluted tubule, PCT. See, clear cell variant as well as papillary variant both arises from PCT. What is the most common gene mutated? The most common gene mutated is VHL gene, and this VHL gene is located on which chromosome number? It is located on chromosome number 3. In this VHL gene, there are two kind of processes which are going to occur. One is deletion and second is translocation. So in this, there is either deletion or translocation. Okay, you must be knowing that for translocation we need two chromosomes. So one is 3, which is fixed. So what is the other chromosome? It's 36, 38, 311. Clear? So it is 36, 38, 311. right? Next is papillary variant. So see, second is papillary. This papillary variant of RCC is the most common type of RCC seen in patients of cystic disease requiring hemodialysis, right? So this is the most common type seen in patients of cystic disease requiring hemodialysis. What does it mean? Imagine a patient is having autosomal dominant polycystic kidney disease. So patient is having cystic disease. In 5th and 6th decade, if the patient is going to develop renal failure, patient requires hemodialysis or renal transplantation, you are going for hemodialysis in this patient. And if a tumor is going to appear or develop in this patient, what is that tumor? It's papillary. So it's most common type seen in patients having cystic disease requiring hemodialysis, right? We discussed that it arises from PCT. The older concept was telling that papillary carcinoma arises from DCT, but the new concept says that both clear cell variant and papillary arises from PCT. Now see, papillary carcinoma, in this papillary variant, what is the name of gene mutated? The name of gene mutated is MET gene. Okay, and what is the location of this MET gene? It is located on chromosome number 7. And what kind of process is occurring? Yes, there is trisomy. So you know that this trisomy involves one chromosome 7. Apart from 7, sometimes chromosome number 16 and 17 is also involved. So what are the chromosomes involved? It's 7, 16 and 17. Frequently asked question. Second pathological characteristic of this tumor, that the tumor is hemorrhagic and cystic. Papillary variant, the tumor is hemorrhagic and cystic, and in this tumor there is dystrophic calcification, and you must be knowing what's the name of that dystrophic calcification, and that's Samoma bodies. So important point, that Samoma bodies are seen. Clear? And what are these Samoma bodies? This is the dystrophic calcification. We discussed that what are the other tumors in which Samoma bodies are seen, and the mnemonic is PSM, right? So the mnemonic is P, S and M. P means papillary carcinoma thyroid and papillary variant of RCC. So this is papillary carcinoma thyroid and papillary variant of RCC. S means serous cyst adenoma ovary. So this is serous cyst adenoma. So serous cyst adenoma ovary. And M means meningioma. Clear? The third variant is chromophobe variant, and this is frequently asked in exams. So third is chromophobe. Okay. The question which is frequently asked related to this chromophobe variant is that this is the variant which is having best prognosis. You have to remember. So this is the variant which is having best prognosis. Okay. It arises from intercalated cells of collecting duct. So it arises from intercalated cells of collecting duct. Clear? Lots of questions are asked in pathology that this tumor is having plant cell appearance. Why? It is said that this tumor is having plant cell appearance because this tumor is having relatively clear cytoplasm. There is fine chromatin, thickened cell membrane, and there is perinuclear halo. Okay. So what is the another feature that this tumor is having? Plant cell appearance. Clear? Now, what are the chromosomes lost in chromophobe variant? So the chromosomes which are lost 1, 2, 6, 10, 13, 17, 21 and Y. These are the chromosomes which are lost. In All India, one question was asked, and in that question only 2 chromosomes were mentioned. Which were mentioned? Out of this list, 1 and Y were mentioned, so you have to remember at least these two. So how many chromosomes are lost? Here you can see there is loss of multiple chromosomes, so it is characterized by multiple chromosome losses. What? Multiple chromosome losses with extreme hypodiploidy. Extreme hypodiploidy. Okay, so multiple chromosome losses with extreme hypodiploidy. This is seen in chromophore variant, and we discussed that this is the variant which is having best prognosis. Next variant is Bellini duct carcinoma. So this is Bellini duct. So it's Bellini duct carcinoma. So it arises from collecting duct. So what's the origin? It arises from collecting duct. It's rare and having poor prognosis. So this variant is rare. It arises from collecting duct and it's having poor prognosis. Two questions which are asked in pathology. One, that it is associated with Hobnail pattern, and this tumor is having excessive fibrosis, so it shows desmoplastic reaction. So it shows Hobnail pattern and it is associated with desmoplastic reaction. Okay, we discussed that this desmoplastic reaction is seen in intense desmoplastic reaction is seen in carcinoma pancreas. Desmoplastic reaction is also seen in carcinoid tumors and in Bellini duct carcinoma. Now see one question which was asked in JIPMER. A 10-year-old child who is having sickle cell trait. 10-year-old child of Africa having sickle cell trait. What is the most common type of RCC seen in this particular child? So it's the medullary variant. Medullary variant of RCC is exclusively seen in children having sickle cell trait. So this is important. Which variant is the medullary variant? And this medullary variant is exclusively seen in children having sickle cell trait. Clear? So these are the important variants of RCC. 4 questions which are frequently asked. First, what's the most common variant of RCC? Clear cell. Most common variant seen in patients of cystic disease requiring hemodialysis? Papillary. Best prognosis is seen in chromophobe. Exclusively seen in children having sickle cell trait? Medullary. Okay, so this is the pathological aspect. Let's discuss the surgical aspect. So first question, what are the names of RCC? Renal cell carcinoma. What are the names? So first, it is known as, or the other name is hypernephroma. Other name is Gravid's tumor. It's Gravid's tumor. Other name is internist tumor. Internist tumor, and the other name is radiologist tumor. Okay, so why these names? First important point, that this RCC arises from upper pole or lower pole. So see, this is the kidney and RCC arises from upper pole. So when this tumor was diagnosed initially, both surgeons and pathologists were thinking that since the tumor is arising from upper pole, most probably the origin is adrenal. So that's why the name is hypernephroma. So what? It arises from upper pole. That's why it was called hypernephroma, means above kidney. Gravid's was a pathologist. He concluded that the origin is renal, not the adrenal, and that's why it's known as Gravid's tumor. So Gravid's concluded that origin is renal. So the origin is renal, and that's why it is known as Gravid's tumor. Why it's known as internist tumor? Because of paraneoplastic manifestations associated with RCC. So internist tumor because of paraneoplastic manifestations. Okay. And see, in RCC there is prolonged period of stable disease. Means for long duration of time the tumor is there but it is asymptomatic. So this is diagnosed incidentally on radiological investigations, and that's why it is known as radiologist tumor. So it is incidentally diagnosed on radiological investigations. Clear? So these are the various names. So question, what is the most common malignancy of kidney? The most common malignancy of kidney is RCC. So RCC is the most common malignancy of kidney, and generally it is seen in which decade? 6 to 7 decade. It is more common in males or females? Males. Okay, so important points: more common in males, generally seen in 6th to 7th decade, and this is the most common malignancy of kidney. Now coming to the risk factors. What are the risk factors? Tobacco in any form. Either person is chewing tobacco or smoking tobacco. Okay. So what are the risk factors? First, tobacco or smoking, chronic analgesic nephropathy, chronic analgesic nephropathy, and cadmium or asbestos exposure. Cadmium or asbestos. Cadmium or asbestos exposure. Okay. Then there are important unique features of RCC. So what are those unique features of RCC? The features which are generally not seen in malignancies. Okay. So first, despite of being a malignancy, it is having a false capsule around the tumor. So it is associated with what? Pseudocapsule. So see the unique properties or unique features of RCC. First, this tumor is having pseudocapsule, and we discussed that there is prolonged period of stable disease. There is prolonged period of stable disease. Okay. Third important point, that this is refractory to cytotoxic agents. Means the conventional chemotherapy which we are using for other tumors, this RCC is refractory. So this is refractory to cytotoxic agents. Refractory to cytotoxic agents means conventional chemotherapy. But this tumor responds to biological response modifiers like combination of interleukin 2 and interferon alpha. So it shows response. It shows response to biological response modifiers. Okay, and what's that? We use interleukin 2 plus interferon alpha. So it shows response to biological response modifiers, interleukin 2 and interferon alpha. What is the another important property? That RCC shows the property of spontaneous regression. Can you believe that a patient is having RCC and on its own it disappears? So it's having the property of spontaneous regression. And see, some of the Babas, some of the religious leaders are taking the advantage of this property. Suppose a patient is having RCC and the Baba is going to touch that patient and RCC disappears. What? Baba is going to take the credit. Not only RCC, there are 5 tumors which are showing the property of spontaneous regression. So spontaneous regression is seen. And this is the favorite question of PGI Chandigarh, that what are the tumors in which spontaneous regression is seen, and the mnemonic is NCR-MR. It is NCR-MR. So N means neuroblastoma. C means choriocarcinoma. R means retinoblastoma. M means malignant melanoma. R R means RCC. So these are the 5 tumors in which spontaneous regression is seen, and this is frequently asked in PGI Chandigarh. Now coming to the clinical features of RCC. RCC is associated with a triad, and what are the components? It is associated with a triad and the components are mass, pain and hematuria. Mass, pain and hematuria. Okay, but see, this triad is seen only in 10% patients who are having advanced disease, right? And that's why what's the name of this triad? It's too late triad, because if the patient is having the combination of these 3 symptoms, we are going to tell the patient that it's too late. So what? It's too late triad. So why it's known as too late triad? Because it is seen in 10% patients, only 10% patients having advanced disease. Okay, one important point. What is the second important point? That out of these 3, which one is the most common symptom? And the most common symptom or presentation of RCC is what? Hematuria. So this is the most common symptom. Okay, one practical question which was asked indirectly in AIIMS. Now see the question. This is kidney, this is renal vein, this is inferior vena cava, this is left renal vein, and this is the left kidney. You know that left gonadal vein is going to drain into left renal vein. Now here, this is what? Deep ring. Now this is the superficial ring, and then there are tributaries around testes, means venous drainage of testes, and this is known as what? Pampiniform plexus of veins. Okay, this is the normal anatomy. You must be knowing that RCC is having hematogenous spread, and in RCC there is tumor thrombus also. So see, if there is hematogenous spread, you can see this tumor thrombus is going first in renal vein, then this tumor thrombus goes into IVC, and in certain patients the tumor thrombus can reach up to right atrium. Now see the left side. Suppose there is a tumor thrombus, so this tumor thrombus is going into the left renal vein. So whenever this tumor thrombus is going into left renal vein, what? It can compromise the venous drainage via this left gonadal vein, and when the venous drainage is compromised, there is increased pressure left gonadal vein, and if there is increased pressure in this left gonadal vein, what will happen? There is dilated and tortuous pampiniform plexus of veins around testes, and what's the name of this condition? This is varicocele. Now how this varicocele is different from usual or normal varicocele which is seen in young patients? See, here the varicocele is seen in elderly patient, 5th to 6th decade. The duration is short. There is important property of varicocele that when patient is going to lie down, what? It is going to decompress. But since here there is tumor thrombus in the renal vein, it's not going to decompress. So this is non-reducing varicocele. So this is suggestive of suspicious varicocele, and suspicious varicocele is seen in RCC. Okay, so there is another feature which is associated with RCC. This is suspicious varicocele, and this suspicious varicocele, what are the features? It is seen in elderly. There is short history, and it's non-reducing. This is non-reducing. Okay, and this suspicious varicocele is suggestive of what? RCC. Now see the paraneoplastic manifestations associated with RCC. We discussed that paraneoplastic manifestations are seen in both HCC, hepatocellular carcinoma, and RCC. So what are the paraneoplastic manifestations of RCC? First important point, that what is the most common paraneoplastic manifestation? And the most common paraneoplastic manifestation is raised ESR, and it is seen in more than 55% patients. These patients might have anemia, polycythemia. Patient can develop hypertension, there is hypercalcemia, and patient might be having non-metastatic hepatic dysfunction. And what's the name of this condition? Non-metastatic hepatic dysfunction. This is known as Stauffer syndrome. So this is Stauffer syndrome. Okay, now see, what is the problem in RCC? In RCC, there is a tumor, and this tumor is going to replace the kidney over a period of time. So see, whenever this tumor is non-functional, it is going to replace the kidney, and over a period of time, what happens? The erythropoietin production is going to decrease. So what happens? Here, tumor replaces kidney, and because of this, what happens? Yes, there is decreased production of erythropoietin, and because of that, there is anemia. Suppose the patient is having functional tumor. If the tumor is functional and it is producing erythropoietin, so because of this functional tumor, there is increased erythropoietin, and because of this increased erythropoietin, there is polycythemia. One student asked me that, sir, how it is possible that the same patient is having anemia and polycythemia? Be careful that all these manifestations are not present in all the patients. Depending upon the tumor characteristics, patient will be having either anemia, polycythemia, hypertension, hypercalcemia. It's not necessary that all these manifestations are there. Imagine if the patient is having tumor which is producing or secreting excessive renin. So because of that, there is activation of renin-angiotensin system, and what will happen? Hypertension. One question which is frequently asked, that in malignancy there is a substance which is responsible for hypercalcemia. So which substance or which hormone is responsible for hypercalcemia induced by the malignancy induced hypercalcemia? And that is PTHRP, parathyroid hormone related peptide. It is because of parathyroid hormone related peptide. And this Stauffer syndrome, it is because of production of IL-6. What is Stauffer syndrome? It is non-metastatic hepatic dysfunction. Non-metastatic hepatic dysfunction. So here you can see the term is self-explanatory. There is no metastasis to the liver. Despite of that, patient is having hepatic dysfunction. So generally these patients have jaundice. Okay, bilirubin is raised, and whenever we are going for ultrasound or CT, there is no mass lesion in the liver. So this is non-metastatic hepatic dysfunction, Stauffer syndrome. It is because of IL-6. Now out of these 6 paraneoplastic manifestations we discussed, which one is most common? It's raised ESR. Out of these 6, which is completely managed medically, and that is hypercalcemia. So which drug is given? We give bisphosphonates. And what is the drug of choice in bisphosphonates? We give zolendronate or zolendronic acid. So here we give zolendronate or zolendronic acid. And you must be knowing that whenever we give bisphosphonates, patient has to take the drug with plenty amount of water, and in standing position only patient has to stay for minimum half an hour. Why? Because this drug is associated with which side effect? Esophagitis, if it comes in contact with the epithelial lining of esophagus, right? So these are the important points related to paraneoplastic manifestations. Now see the route of spread and metastasis. We discussed that what is the most common route of spread, clear? And the most common route of spread is hematogenous, clear? And why are this hematogenous spread? The tumor can reach up to the lungs. So what is the most common site of metastasis? The most common site of metastasis, and that's lungs. In lungs, what kind of secondaries are seen? This question was asked many times as an image based question. So you must have seen cannons in front of forts in Rajasthan, in UP. Okay, so these are the cannonballs. For cannon, these kind of balls were used, cannonballs. So whenever we are going to perform the X-ray, can you see what kind of appearance is seen? This is the appearance. So it's looking like cannonballs, and this is what? Cannonball secondaries. So these are cannonball secondaries. So in RCC, cannonball secondaries are seen. Cannonball secondaries are also seen in one variant of testicular tumor, the variant which is having early hematogenous spread, early pulmonary metastasis, and worst prognosis. And what's that variant? Choriocarcinoma. So this is cannonball secondaries. These are cannonball secondaries, most commonly seen in RCC, also seen in choriocarcinoma, variant of testicular tumor. Choriocarcinoma, a variant of testicular tumor. Now see, we discussed the bone metastasis in males. So what is the most common primary for bone metastasis in males? And that is carcinoma prostate. And what kind of secondaries are seen in carcinoma prostate? In carcinoma prostate, osteoblastic secondaries are seen. So most common primary for osteoblastic secondaries in males, it is CA prostate. And most common primary for osteolytic secondaries in males, that is RCC. What is the special features of secondaries caused by RCC? These are hypervascular and these are osteolytic. So this is also known as what? Pulsatile secondaries. So in RCC, there is pulsatile secondaries, and there is another tumor or malignancy of thyroid which is associated with pulsatile secondaries. Which one? Follicular carcinoma thyroid. Okay. So in RCC, there is pulsatile secondaries. What do you mean by pulsatile? It means it's osteolytic and hypervascular. So this is osteolytic and hypervascular, and it is seen in RCC and follicular carcinoma thyroid. Now coming to the diagnosis, we discussed what is the investigation of choice for diagnosis of RCC. It is CCT. So 3 questions which are asked. See the language of question. Investigation of choice for diagnosis of RCC, and that is CCT. Okay. Now see the twist in the language. Investigation used to differentiate tumor thrombus from bland thrombus. Sometimes the thrombus which is there in the renal vein or IVC, it might contain tumor or not. If it doesn't contain the tumor, it is known as bland thrombus. So investigation used to differentiate tumor thrombus from bland thrombus. And which investigation? Here we use MRI. This is MRI. And gold standard investigation for IVC invasion, and that is inferior vena cava gram or vena cavography, right? So what's the gold standard investigation for IVC invasion? So you have to read the question carefully and see the language. So here it's the vena cava gram, inferior vena cava gram or vena cavography. So these are the 3 questions asked frequently. AJCC 8th AJCC TNM classification and staging for RCC. So what's the 8th AJCC TNM classification? And it's very easy to remember. Okay, so first see what's T1A. T1A means the size of tumor is up to 4 centimeter, right? What is T1B? It's more than 4. It's more than 4 to 7 centimeter. What is T2A? It's more than 7 to 10 centimeter. And what's T2B? This is more than 10 centimeter. So it's easy to remember. And in all these four conditions, the tumor is confined to kidney. So here, in all these conditions, what? Tumor is confined to kidney. So this is T1A, T1B, T2A, T2B. T3 is further divided into T3A, T3B, T3C. See, what's T3A? So in T3A, the tumor grossly extends into renal vein, grossly extends into renal vein or its segmental branches, or its segmental branches. Clear? And the second component is, if the tumor invades, this is also included in T3A, if the tumor invades perirenal and or renal sinus tract, perirenal and or renal sinus tract, okay, without involvement of Ureter's fascia, without involvement of Ureter's fascia. Clear? So this is T3A. Now when the tumor grossly extends into inferior vena cava but it's located below diaphragm, it is T3B, and if it's above diaphragm, it is T3C. So what is included in T3B? Tumor extends grossly into IVC below diaphragm, grossly extends into IVC below diaphragm. Okay, and what happens here, you have to mention below. And in T3C, it extends grossly into IVC above diaphragm, or when the tumor is going to invade the wall of IVC, that is also included in T3C. Or tumor invades in T3C, invades wall of IVC. Okay. Now what is T4? What is included in T4? When tumor extends beyond Ureter's fascia. So that's T4. So here tumor extends beyond Ureter's fascia. Clear? So this is T. Okay. After that, N0 means lymph node metastasis, and distant metastasis is very easy. N0 means no lymph node metastasis, means no metastasis to regional lymph nodes. N1 means metastasis to regional lymph node. M0 means no distant metastasis, and M1 means distant metastasis. So this is TNM classification. Now see the staging, which is also very, very easy. So if you see the stage 1, it is T1. Clear? Stage 2, it's T2, and stage 3, it's T3. Or first lymph node comes here, so it's T1 to T3 N1. And what is included in stage 4? It's T4. Okay, or TNE, NNE, M1. So how to remember? Just encircle these stages. These are characteristic features. So whenever it's M1 or T4, it is stage 4. When first lymph node comes, it becomes stage 3. And here stage 1 is T1, stage 2 is T2, and stage 3 is T3, or T1 to T3 N1. So this is the staging. Now coming to management. See, in most of the patients who are having RCC, doesn't matter whether they have localized or metastatic RCC or advanced RCC, we perform radical nephrectomy because it is a debulking or cytoreductive surgery. Also, it's a type of cytoreductive surgery. So the treatment of choice for RCC is radical nephrectomy. Then there are important situations where we can preserve the kidney and we can go for nephron sparing surgery. Two important points related to the management. First important question, what is the treatment of choice for RCC? Nothing is mentioned this statement, and the answer is radical nephrectomy. Why? It's a type of cytoreductive surgery which decreases the tumor load. Radical nephrectomy, right? There are certain situations where we can preserve the kidney, right? Imagine if the size of tumor is up to 4 centimeter. In that case, we can go for nephron sparing surgery. Nowadays, certain books says that nephron sparing surgery can be performed up to 7 centimeter. But in Campbell, it's written that preferably it should be done for the tumor up to 4 centimeter. Okay. So, first important point, what are the indications? Indications of nephron sparing surgery. There are certain common sense indications. Imagine patient is having a single kidney, solitary kidney is there in the body, and in that case patient is having RCC in the kidney. So we have to preserve the kidney. If you are going to remove the kidney, patient will die because of renal failure. So we have to go for what? Nephron sparing surgery. Imagine patient is having bilateral RCC. In both kidney patient is having RCC. Again we have to go for nephron sparing surgery. And third situation, imagine a patient is having RCC but the contralateral kidney is also diseased, having renal artery stenosis. So in all these situations, we have to go for nephron sparing surgery. So first, size of tumor up to 4 centimeter, and the latest update given in certain books says up to 7 centimeter. Clear? Second, RCC in solitary kidney. Patient is having a single kidney, and in that also patient developed RCC, bilateral RCC, and RCC with diseased contralateral kidney. And which particular disease in which function can go anytime? The person having renal artery stenosis. So in these cases we go for nephron sparing surgery. Now if a patient is having advanced or metastatic RCC, clear? In that case, what is the first line agent? So initially first line agent was interleukin 2 plus interferon alpha, but nowadays it is sunitinib. So if a patient is having advanced and metastatic RCC, in that case the first line agent is sunitinib. Clear? In HCC we discussed it was sorafenib, and here what's the second line? And this is IL-2 plus interferon alpha. This is IL-2 plus interferon alpha. So this is how we manage RCC. There are certain named stagings and gradings which are asked in urology. Okay, so see, there is Robson staging, and there is Fuhrman's grading. Robson staging and Fuhrman's grading. This is for RCC. This is for RCC. Okay. Then there is Jackson staging. Jackson staging is for carcinoma penis. So Jackson staging, this is for carcinoma penis. And there is Gleason grading. Gleason grading is for carcinoma prostate. So there is Gleason grading, and this Gleason grading, this is for carcinoma prostate. Before discussing Wilms tumor, we are going to discuss the pediatric tumors because these are frequently asked one-liner questions. Okay, so in pediatric tumors, what is the most common intra-abdominal malignancy in children? And that's neuroblastoma. What is the most common extracranial solid malignancy of childhood? Neuroblastoma. What is the second most common intra-abdominal malignancy in children? And that's Wilms tumor. And you know, Wilms tumor is the most common primary renal malignancy of childhood. Okay, so these are important points in pediatric tumors. So first, most common intra-abdominal malignancy in children. Okay, it's neuroblastoma. And most common extracranial, means outside cranial cavity, extracranial malignancy in children. And for both of these questions the answer remains same, and that's neuroblastoma. Now see the change. What is the second most common intra-abdominal malignancy in children? So second most common intra-abdominal malignancy in children is Wilms tumor. This is Wilms tumor. And you know, Wilms tumor is the most common primary renal malignancy in children. So this is most common primary renal malignancy in children. Okay, then what is the most common renal tumor? See, these are malignant tumors. What is the most common renal tumor of infancy? And that is congenital mesoblastic nephroma. What is the most common soft tissue tumor in children? And that is rhabdomyosarcoma. Overall, if we see overall, what's the most common malignancy of childhood? And that's leukemia. Which type? ALL. And after leukemia, what is the second most common type of malignancy in children? And it's the brain tumor, right? So most common renal tumor of infancy, renal tumor of infancy, and that is congenital mesoblastic nephroma. It's the congenital mesoblastic nephroma. Clear? Most common soft tissue tumor in children, most common soft tissue tumor in children, this is frequently asked question, and that's rhabdomyosarcoma. It's the rhabdomyosarcoma. Overall, most common malignancy of childhood. So what's the most common malignancy of childhood? Clear? So this is leukemia. Which type? ALL. And after leukemia, which tumor is most common? It is brain tumor. It's brain tumor. Okay, so suppose indirect question is asked that what is the most common solid malignancy of childhood? Leukemia is a malignancy of blood cells, so most common solid malignancy of childhood, and that's brain tumor. So all these are the important questions asked frequently. We are going to discuss Wilms tumors first. See, Wilms tumor. So what is the other name of Wilms tumor? You know, the other name of Wilms tumor is nephroblastoma. It's nephroblastoma, and we discussed this is the most common primary renal malignancy in children, and it's the second most common intra-abdominal malignancy in children. Generally, in which particular age group this Wilms tumor is seen? It is seen in 2 to 5 years of age. And there is a gene responsible for Wilms tumor. What's the name of that gene? WT1 and WT2. These are the two genes responsible. And what is the location of these genes? Genes WT1 and WT2, and both of these genes are located on chromosome number 11. Generally, this Wilms tumor is unilateral. There is one question which is asked in pathology, that what are the three components of Wilms tumor, and how you can remember the mnemonic is BEST. So the components of Wilms tumor, it's BEST. B means blastema. It is blastema. E means epithelium, and ST means stroma. Okay. Now there is one question which is frequently asked in medicine, in surgery, in pediatrics. What are the variants of Wilms tumor? So one is Wagner syndrome, Wagner syndrome. Second is Dennis-Drash syndrome, and third is Beckwith-Wiedemann syndrome. Okay, one by one we are going to see. First, Wagner syndrome. Clear? So here you can see the mnemonic also Wagner. So what are the components? W means Wilms tumor. A means there is aniridia. There is aniridia. G means genital anomalies. Genital anomalies. And R means retardation. What kind of retardation? There is mental retardation. Clear? What kind of? It's the mental retardation. Clear? So this is Wagner. Second is Dennis-Drash syndrome. So see what are the components of these Dennis-Drash syndrome. These patients have gonadal dysgenesis. What kind of? The patients are having pseudo-hermaphroditism, and it's male or female pseudo-hermaphroditism. So this is male pseudo-hermaphroditism. So apart from gonadal dysgenesis, these patients have renal failure. Okay, so these patients have gonadal dysgenesis, and we discussed which type of male pseudo-hermaphroditism, and the patients have renal failure. Clear? And the most frequently asked names is Beckwith-Wiedemann syndrome. So what are the components of Beckwith-Wiedemann? Beckwith-Wiedemann syndrome. Clear? So these patients have hemihypertrophy and visceromegaly. What is visceromegaly? There is hepatomegaly, splenomegaly. There is enlarged tongue, that's known as macroglossia. There is omphalocele, and there is a tumor in liver, hepatoblastoma. So what are the associations of this? The patients have hemihypertrophy. Patients have visceromegaly, means hepatomegaly, splenomegaly. So there is visceromegaly. There is macroglossia, so that's enlarged tongue. There is omphalocele and hepatoblastoma. So these are the associations. Now coming to the clinical presentation. See, the clinical presentation is very similar to RCC, but the triad is different. What was the triad in RCC? There was mass, pain, and hematuria. In Wilms tumor also pain is there, but the pain is not the component of triad. So here the triad is mass, fever, and hematuria. And fever is so characteristic. When you remove the tumor, fever disappears. So what's the triad? See the clinical features of Wilms tumor. These patients have mass, patients have fever, and there is hematuria. What kind of hematuria? These patients have microscopic hematuria. This is the triad. And fever, generally it disappears after tumor resection. So we discussed pain is there in Wilms tumor, but pain is not the component of triad. There is other similarity with RCC. In Wilms tumor also there is hematogenous spread. And if there is hematogenous spread, what is the most common site of metastasis? Lungs. We can diagnose the tumor with CT. But what for nephroblastoma component, the MRI is better because it gives better soft tissue details, right? So here, so the route of spread, it is hematogenous. Clear? And just like RCC, what is the most common site of metastasis? The most common site of metastasis is lungs. Right? So diagnosis, we discussed which one is better investigation. So investigation of choice for diagnosis is MRI, and if it's not there in the option, you can go for CCT. So why MRI? Is because of better soft tissue details, right? Now Sometimes on the basis of investigations, on the basis of presentation, you have to differentiate whether the patient is having Wilms tumor or patient is having neuroblastoma. So Wilms tumor is nephroblastoma and neuroblastoma. How you will differentiate? See, generally Wilms tumor doesn't cross the midline, but neuroblastoma can cross the midline. And you can differentiate these tumors on the basis of calcification also. So see how this is Wilms tumor and this is neuroblastoma. So what kind of calcification is seen in Wilms? In this case, there is crescent shaped, and these are discrete and peripheral. Discrete and peripheral calcification, whereas in neuroblastoma it's finely stippled calcification. So it's finely stippled. So it's fine and stippled calcification. Clear? Generally, Wilms tumor doesn't cross the midline, so it cannot cross midline. Okay, and neuroblastoma generally it crosses midline. Clear? So on the basis of radiological investigations, you can differentiate whether this is Wilms tumor or neuroblastoma. Now see, the treatment protocol is also very similar to RCC. What is the treatment of choice for Wilms tumor? It is radical nephrectomy. Right? We discussed in breast that what is the most important prognostic factor in most of the malignancies. Most important prognostic factor in most of the malignancies, and that is stage. Stage means it includes T and M, all the three parameters, right? But there are two exceptions. What is the most important prognostic factor in Wilms tumor? In Wilms tumor, it is histology followed by stage, and in soft tissue sarcoma, it is tumor grade. So see, important point related to the treatment. What is the treatment of choice for Wilms tumor? It is radical nephrectomy. So this is radical nephrectomy. Now coming to the stage, most important prognostic factor for most of the malignancies is stage. Clear? So what are the exceptions? Exceptions. First is Wilms tumor. In Wilms tumor, it is histology followed by stage. See, in certain pathology books, stage is given as the most important prognostic factor in Wilms tumor, but in Campbell urology, it's the histology. So it's the histology followed by stage. And if we see soft tissue sarcoma, in soft tissue sarcoma, it's the tumor grade. Clear? Now what is the application of this important fact? See, if Wilms tumor is there, I'm going to perform the radical nephrectomy. After that, the specimen is sent to pathology department, and from pathology department get the biopsy report, right? If in the report it is mentioned that histological factors are good, in that case no further treatment is required. And if in the report it is mentioned that the histological factors are adverse, so in cases of adverse histological factors, within 5 days we had to start chemotherapy, and within 10 days we had to give what? Radiotherapy. But what is the important point which should be mentioned? In cases of adverse histological factors. Clear? So in cases of, see histology, so in cases of adverse histological factors, this is important one-liner asked frequently, chemotherapy should be started. Chemo within 5 days. You have to remember the days. And radiotherapy should be started within 10 days. So remember, within 5 days we have to start chemotherapy. Within 10 days we have to give radiotherapy if histological factors are adverse. Now which chemotherapy regimen is given in Wilms tumor? It is VCD. Okay, so it is vincristine, cyclophosphamide, doxorubicin or dactinomycin. Okay, so this is vincristine, cyclophosphamide, doxorubicin or dactinomycin, doxorubicin or dactinomycin. Okay, what are the staging systems for Wilms tumor? There is pre-chemotherapy staging and there is post-chemotherapy staging. The pre-chemotherapy staging was developed by National Wilms Tumor Staging Group, and post-chemotherapy staging was developed by International Society of Pediatric Oncology. Okay, so see, this was also asked once in All India. Stagings: one is pre-chemotherapy staging, pre-chemotherapy staging, and this is post-chemotherapy staging. Clear? Pre-chemotherapy staging, it was developed by National Wilms Tumor Staging Group, and this post-chemotherapy staging, it was developed by International Society of Pediatric Oncology. Okay, in short, it is known as SIOP, Society of International Oncologists of Pediatrics. Right? Now see, pre-chemotherapy staging. Okay, so staging is done when you remove the tumor and send it to the pathology department. It means we perform surgery and staging. Pre-chemotherapy means before chemotherapy. So surgery and staging is done before chemotherapy. Post-chemotherapy means surgery and staging. It's done after chemotherapy. So this is done after chemotherapy, right? So it's simple. These two are asked in exams and these are for Wilms tumor. Another important malignancy is carcinoma renal pelvis. So see, carcinoma renal pelvis, and it's very easy to understand this malignancy. Okay, first see the anatomy. This is kidney, this is ureter, this is bladder. Okay, now in the kidney, this is what? Pelvis, this is the ureter, and this is the bladder. Okay, what is the similarity in all these three? The similarity in all these three organs is what? That their epithelium is same. Which one? Transitional epithelium. So in pelvis, in ureter, in bladder, the epithelium is transitional epithelium. Now here, what is the most common malignancy in all these three organs? It is the transitional cell carcinoma. What is the risk factor for this transitional cell carcinoma? Smoking. And what is the most common symptom of this transitional cell carcinoma? Is the painless gross hematuria. So can you see similarity? This is known as field defect. What is field defect? It means a common risk factor is going to increase the risk of malignancy in the whole field. So what is that common risk factor? Smoking. And it is going to increase the risk of malignancy in the whole field. Right? It means, so this is field defect. Second, whenever we are planning the treatment, in the treatment, whatever the organs which are at the risk of malignancies, generally all those organs or part of those organs are removed. Clear? So whenever we are planning the treatment for carcinoma renal pelvis, what we are going to remove? Kidney, ureter, and cuff of bladder where this ureter is going to drain. One principle. Smoking is a risk factor. Not only smoking, for transitional cell carcinoma, analgesics like phenacetin, industrial dyes, solvents are risk factor. So those will be risk factors. The symptom, most common symptom of transitional cell carcinoma is painless gross hematuria. So here you will find that most common symptom is painless gross hematuria. Clear? So see one by one. First, what are the risk factors? So it's the smoking, analgesics like phenacetin, industrial dyes or solvents, and Balkan's nephropathy. Balkan's nephropathy. Okay, most common histological type. This is the transitional cell carcinoma. See the clinical features. So these patients have painless gross hematuria. Apart from this painless gross hematuria, since the tumor is there, so what? If you can palpate, you can feel that there is mass in the flank. So these patients have flank mass, and irritative voiding symptoms. These patients have irritative voiding symptoms. Right? Now, how we are going to make the diagnosis? What is the important point related to this transitional epithelium? Can you see? In the transitional epithelium, there is multi-layered cells, so multiple layering of cells in this epithelium, and that is responsible for stretching of the epithelium. But what happens? There is poor cohesion between these cells. It means, what is the problem? There is frequent shedding of these cells in the urine. So if a patient is having malignancy and you are going for urinary cytology, you can diagnose that this patient is having transitional cell carcinoma. So to make the diagnosis, what we do, since the malignancy is in the pelvis, we go for ureteroscopic brush cytology. What? Ureteroscopic brush cytology. So how it's done? You can see. So this is ureteroscopic, and here brush cytology. So by this ureteroscopic brush cytology also you make the diagnosis. So diagnosis, we can make the diagnosis by ureteroscopic brush cytology. Okay. Suppose we are going to perform IVP. On IVP, we can see that there is filling defect. So on IVP, we can find filling defect. Okay. Now there is a simple concept we discussed. Suppose this is any tubular structure. Tubular structure means it can be ureter, it can be bile duct, it can be small bowel. Now what happens? Suppose there is obstruction. So in tubular structures, if there is obstruction, the proximal segment is distended or dilated and the distal segment is collapsed. Now see what's the problem here. This is kidney and this is the ureter. So what is the problem? Here is the tumor. So obviously this proximal segment will be dilated, but there is important finding that even the part of ureter which is distal to the tumor, that is also dilated. Why? Because there is shedding of this epithelium, shedding of these cells. So even distal part is also dilated, and this is known as what? This is known as goblet sign. So even distal part of ureter, means the part of ureter distal to obstruction, is also dilated. This is goblet sign. Imagine I'm going to insert a stent. If I'm going to insert a stent in the ureter, what happens? There is coiling of the stent distal to obstruction, and when there is coiling of the stent distal to obstruction, this is known as Bergman sign. So this coiling of stent distal to obstruction, this is known as Bergman sign. Okay. Sometimes image based question is asked. So this goblet sign is seen on RGP, that is retrograde pyelogram. So in this image of retrograde pyelogram, RGP, what you can see, here is the tumor. So this is the obstruction, and this is the part of ureter which is dilated. So there is dilated ureter distal to obstruction. Okay. And what is the name of this sign? This is goblet sign. Clear? So these are the indirect evidences of the tumor. By the way, what is the investigation of choice for diagnosis of carcinoma renal pelvis? It is the CT urography. So the investigation of choice for diagnosis, this is CT urography. And we discussed the field defect. That's why what is the treatment? In the treatment, I have to remove the kidney, I have to remove a ureter on that side. So it is nephroureterectomy, and simultaneously I will remove I will remove this kidney, ureter, and cuff of bladder where this ureter is going to drain. So this is the adequate treatment. So what's the treatment for carcinoma renal pelvis? This is nephroureterectomy, nephroureterectomy plus removal of cuff of bladder, removal of cuff of bladder. Clear? So this is how we treat carcinoma renal pelvis.